So what is the physiology behind prone position? Definitely there would have been a physiology wherein with a lung which is a severe ARDS lung has responded to a proning position. So one thing is the lung is divided into a ventral part and a dorsal part. So what happens in a supine position, the dorsal part of the lung receives more perfusion, but it does not receive adequate ventilation. So as the gravity goes down, the perfusion is higher, but there is no ventilation. So definitely there is a ventilation perfusion mismatch which is happening. In addition to that, the lower part of the lung or the dorsal part of the lung are on a compressed part, are compressed because of the compression of the heart compressions. Then the abdomen contents which compress it. There is definitely a basal atelectasis, and even the upper part of the lung, that is a ventral part of the lung, compresses the dorsal part of the lung. So in this position, when you prone a patient, what happens is this ventilation perfusion mismatch which is occurring between the dorsal and ventral definitely comes down. There is 100% decrease in the pressure which is superimposed by the heart on the lung, and hence the alveolar size, because the dorsal part of the lung is not being compressed with the ventral alveoli, there is a more homogeneous alveolar size on both the sides. See here, you can see in the picture, the homogeneity of the alveoli here when you prone the patient is much better than in a patient who is placed completely in a supine position, wherein the most of the basal part of the lung or the up till the middle of the lung, there is a homogeneous invariability in the alveolar size. So to be more precise, when you place a patient prone, the first thing what happens is the gravitational pressure of the heart and the mediastinum on the lungs is definitely decreased. So when you place a patient supine, this gravitational pressure is very high. This gravitational pressure of the heart and lungs is very high, which on supine position is reduced. In addition to that, the abdominal organ content, especially the liver, and in obese patient the stomach and the bowels, which give a compressive effect on the lungs, is reduced. This decreased compressive effect by the abdominal compression helps us to improve the compliance of the lung. The compliance of the lung is 100% increased. The diaphragmatic splinting has come down. The workload in the diaphragm comes down. So this is another added benefit. In addition to that, there is an expansion of the chest wall which is homogeneous. So we saw that when the patient is in supine position, so the ventral alveoli are very much open, whereas the dorsal alveoli hardly do open. But when you supprone the patient, there is a homogeneous opening, much better compared to the supine position. So this homogeneous openings is much better, and so this ventilation perfusion mismatch is decreased. The heterogeneity of the alveoli is decreased, and the expansion of the lung, the compliance is improved. The compression imposed by the heart, the mediastinal structures as well as the abdominal components is also reduced. So the most important thing which is happening when you prone a patient is recruitment of your dorsal lung. So the dorsal lung which is not getting recruited even by your n number of recruitment maneuvers with your higher PEEP gets recruited very well now, gets recruited homogeneously as compared to your ventral part of the lung. So there is recruitment of the dorsal lung. As I said, there is a better and even distribution of your ventilation perfusion ratio, and because of that there is a decreased transpulmonary pressure in the dorsal lung, because your compression from the abdominal contents, the liver as well as your heart and mediastinal contents is decreased, and because of this homogeneous opening and improved compliance of the lung, there is improvement in hypoxemia which we are totally aiming off. So remember these 4 points. Proning, how does it help? It causes recruitment, better ventilation perfusion mismatch, there is a decreased transpulmonary pressure in the dorsal part of the lung, and ultimately we have